Hi, my name is Casey Pauls, and I'm a DNP student at KU School of Nursing. Today, I am going to talk about targeted temperature management in post-cardiac arrest patients, and specifically examining if it causes decreased mortality. When someone experiences out-of-hospital cardiac arrest, there is very little likelihood that they will survive long enough to even make it to a hospital. In fact, over 90% of those with out-of-hospital cardiac arrest in the United States will not. When cardiac arrest occurs, blood flow to the brain ceases, depriving it of oxygen. The cardiac arrest patient is at great risk for death, and if they have return of spontaneous circulation, they are at risk for permanent brain damage of varying degrees. Targeted temperature management refers to inducing hypothermia in post-cardiac arrest patients who have return of spontaneous circulation, or ROSC, but no apparent neurofunction, meaning that they lack meaningful response to verbal commands. This is a guideline of the American Heart Association. You might be familiar with the term induced hypothermia. The term targeted temperature management replaces induced hypothermia as the preferred nomenclature to reflect that a variety of temperatures are now used. Hypothermia decreases metabolism, reduces oxygen demand, and has a protective effect of brain cells, thus preserving neurologic function. For this project, I'm interested in looking at studies to determine if the exposure to targeted temperature management in post-cardiac arrest patients has a protective effect against mortality. More specifically, mortality at hospital discharge, implying that the patient both survived and also regained enough neurofunction to be discharged from the hospital. The first study to be examined by Weiss and McNett is titled Targeted Temperature Management: Effects of Initial Protocol Implementation on Patient Outcomes. These nurse researchers used a retrospective cohort design to determine if patients with out-of-hospital cardiac arrest had better outcomes, including decreased mortality, length of stay, and discharge disposition, after receiving targeted temperature management, compared to those cardiac arrest patients who did not receive the therapy. Out of a sample of 259 out-of-hospital cardiac arrest patients, only 20 received the targeted temperature therapy. This small number is identified as a weakness of this study. However, according to the odds ratio, the patients who received the therapy were almost 3 times more likely to survive than those who did not. This study took place at one large academic hospital, which meant that the protocol for TTM was the same with every patient, but it is also a limitation because the results might not be generalizable. Henneken's criteria was examined for Weiss and McNett's study. There is no confidence interval identified in this study. Since it is unknown if the number 1 is included in the confidence interval, it cannot be stated that the results are statistically significant. We do not know for sure if the decreased mortality was due to the TTM intervention or due to chance. Selection bias is present due to the nature of this study, and information bias is also present. Gender was controlled in this study as well as the location, as the patients were all in the same hospital. The protocol was controlled. Uncontrolled confounders were the initial shockable rhythm, time down, and any bystander CPR. These study outcomes are consistent and have temporalities, since it is clear that the exposure came first before the intervention, or the exposure came first before the outcome, and there is no dose response. The second study was titled Mortality in Out-of-Hospital Cardiac Arrest Patients Has Decreased in the Era of Therapeutic Hypothermia. The aim of this study was to find out whether hospital mortality of ICU-treated out-of-hospital cardiac arrest patients has changed in the era of TTM compared to the past. So, since we have started implementing TTM, has it made a difference in the mortality of post-cardiac arrest patients or not? This is a Finnish research study that looked at a sample of 3,958 out-of-hospital cardiac arrest patients and compared hospital mortality from the pre-TTM era, years 2000 to 2002, to the TTM era of 2003 to 2008. The strengths of this study were the large sample size, and the results are generalizable to the entire country of Finland. A limitation of note is that only 36.2% of the patients in the TTM era from 03 to 08 had TTM, so it could be hard to prove causality of the lower mortality rates to the TTM when it is well known that medical technology evolves every year and is rapidly changing outcomes for patients. Treatment in 2003 through 2008 was associated with a significantly reduced risk of in-hospital death, according to the odds ratio of 0.54. The cardiac arrest patients in the TTM era cohort were less likely to experience in-hospital mortality than those in the non-TTM era group. The confidence interval is 0.45 to 0.64, and p-value is less than 0.001. Selection bias and information bias are again present. Age and gender were controlled in this study. The initial shockable rhythm was uncontrolled because data was not available. Length of ICU stay and the location of cardiac arrest being out of hospital were also controlled. There was a moderate strength of association with the odds ratio of 0.54. No biological plausibility. Results are consistent, temporality is present, and no dose response. The third and final study examined was another retrospective cohort study titled Effect of Therapeutic Hypothermia on Survival and Neurologic Outcomes in the Elderly. Data was collected from 33 hospitals in Los Angeles County on 1,612 patients aged 65 or older with out-of-hospital cardiac arrest. 552 of those patients received TTM, and the outcome from this study was survival with good neurologic outcome, which was defined as a cerebral performance category 1 or 2 at the time of discharge. A CPC of 1 corresponds to return of normal or mildly impaired cerebral function and independence with activities of daily living. A CPC of 2 corresponds to moderate cerebral disability, but sufficient function to remain independent with activities of daily living. Out of the 552 patients who received the intervention, 493, or 31% of the patients survived to hospital discharge, with 266, or 17% of patients surviving with a CPC of 1 or 2. Adjusted odds ratio was 2.0 with a confidence interval of 1.3 to 3.3. Strengths of this study were that the results are more generalizable due to data from many cardiac arrest centers. There was a large sample size, and there was data on the neuro outcomes of these patients. Limitations include the varying methods and protocols for hypothermia at different institutions. There was no follow-up done past hospital discharge regarding the neuro status, and the use of coronary angiography varied between centers. Adjusted odds ratio for survival with good neurologic outcome after TTM in the elderly population was 2.0 with a confidence interval of 1.3 to 3.3. This suggests that age should not be a reason to withhold TTM treatment. Like the other studies, selection bias is present for this population and information bias is also present. Age was a controlled variable, as well as gender, race, location of arrest being out of hospital, and patients had a shockable rhythm. Witness or bystander CPR was uncontrolled, as with time down. No biological plausibility or dose response for this study, but we do have consistency and temporality like the others. In summary, the intervention of TTM may cause patients to have decreased mortality, and it may protect the neurologic outcome in elderly patients. But the evidence from these 3 studies is moderate at best. Since all of these studies were retrospective, all of the results depend on the integrity and accuracy of the documentation at the time of the events. Also, information bias can affect all of these studies if there were errors made while retrieving the data from the databases or the patient charts. One of the biggest confounders is that no data about the patient's out-of-hospital cardiac arrests were factored into the outcomes of these studies. This could have caused more bias to be present in the studies. The length of time that the patient is pulseless is inversely related to survival, so it is hard to determine if the cardiac arrest survivor survived, hopefully with intact neurofunction, due to the TTM or due to a shorter length of time that they were down without CPR. So it's hard to pinpoint why they survived if they had maybe a short time that they were down. More research is needed on this subject. Very few studies have demonstrated the positive effects of TTM on quality of life or long-term dependence at 6 months or longer after arrest, and I think that this is the data that really matters. Mortality is always a good and easy statistic to measure, but neurofunction and especially quality of life are more meaningful. As previously mentioned, a big confounder is the amount of time the patient is down and pulseless before they are resuscitated. This is difficult data to obtain with this population because when someone goes down at home, there's not someone who jumps out of nowhere and starts timing how long it takes before someone finds them and starts CPR. But when cardiac arrests happen in public, there might be surveillance cameras that could give us this data. There are different methods of inducing hypothermia, such as intravascular cooling versus cooling pads, which should be compared and contrasted. And finally, there's not a lot of literature on the effect of targeted temperature management on in-hospital cardiac arrest and whether or not it should be initiated in these patients. These are the references I used for this presentation. Thank you for listening and have a great day.